Now the topic is benign lesions of the uterus. Benign lesions of the uterus usually include the uterine fibroid, cervical fibroid, polyp. Fibroid is the most common benign tumor of the uterus. It is a solid tumor. Histological, this tumor is composed of smooth muscle and fibrous connective tissue, so named as uterine fibroma, leiomyoma, myoma. Origin, it is of unknown etiology. Hypothesis, it originates from the single smooth muscle cell of the myometrium. Chromosome abnormality in 40% is due to the chromosome 6 and chromosome 7. Risk factor of the fibroid increased factors that increases the probability of fibroid: nulliparity, obesity, increased body mass, PCOS, hyperestrogenic state, black woman, high fat diet, family history. Multiparasity, menopause, occipitals, smoking, all are the factor that reduces the risk for the fibroid growth. It is an estrogen dependent tumor. Estrogen progesterone is incremented as the cause. Estrogen dependency is evidenced by the growth potential is limited during the childbearing period. Increased growth during pregnancy. They do not occur before menarche. Following menopause, there is often cessations of the growth and there is no growth at all. Has more estrogen receptor than the adjacent myometrium. Frequent association of the anovulation. Types of the fibroid, they are the uterine fibroid and the cervical fibroid. Uterine fibroid is further classified into three: interstitial fibroid, intramural fibroid, subperitoneal or the subserous, submucous fibroid. This is a pictorial or the tabulated form of the uterine fibroid classification. The body, interstitial, subserous, submucosa. Subserous is further divided into the three, that is a subserous broad ligament fibroid. It is and the one is the wandering fibroid, also known as a parasitic fibroid. Submucous is sessile and the pedunculated. Cervical is further divided into the four: anterior, posterior, central, and the lateral. This is a pictorial presentation for the multiple fibroids. This is a picture showing the submucous fibroid, and the others is also showing the interstitials and the subserous fibroids. The body, the fibroids are mostly located in the body of the uterus, usually multiple, interstitial or the intramural. Initially, the fibroids are intramural in position, but subsequently pushed outward or inward. Subperitoneal subserous fibroid incidence is 15%. The intramural fibroid is pushed outwards towards the peritoneal cavity. Fibroids are either partially or completely covered by the peritoneum. When completely covered by the peritoneum, it is usually attain a pedicle known as a pedunculated subserous fibroid. On rare occasion, the pedicle may be torn through. The fibroid gets in nourishment from the omentum or the mesenteric adhesion. It is known as ventring or the parasitic fibroid. Submucous fibroid, the intramural fibroid when pushed towards the uterine cavity and is lying underneath the endometrium, it is called the submucous fibroid. This variety is least common and it produces maximum symptoms. Cervical fibroid is very rare. It is in the supravaginal part of the cervix. It may be interstitial or subperitoneal variety and really polypoidal. Depending upon the position, it may be anterior, posterior, lateral, or the central. Now the pathology, the false capsule is formed by the compressed adjacent myometrium. They may are pinkish in color. In contrast to whitish appearance, often tumor. The capsule is separated from the growth by the thin tissue of the tumor. The capsule is separated from the growth by thin tissue, areolar tissue. The blood vessel run this plane to supply the tumor. It is through this plane that the tumor is shelled out during the myomectomy. The periphery of the tumor is more vascular and have more growth potential. Secondary degeneration in the fibroid. It may be hyaline degeneration, cystic degeneration, fatty, calcific degeneration. Fibroid may undergo the atrophy, necrosis may occur, infection, vascular changes, and the sarcomatous changes. Symptoms: most of the fibroids are asymptomatic. Menstrual abnormalities, menorrhagia, metrorrhagia, dysmenorrhea, dyspareunia, subfertility, pressure symptoms, recurrent pregnancy loss, lower abdominal and the pelvic pain, abdominal enlargement. Symmetrical causes of the symmetrical enlargement of the uterus: pregnancy, submucous intramural fibroid, adenomyosis, myohypoplasia, pyometra, hematometra, leukometra, malignancy, CA body, choriocarcinoma, sarcoma. Complication of the fibroid: fibroids may undergo the degeneration, necrosis, infection, sarcomatous changes, torsion of the subserous or the pedunculated fibroid. Hemorrhage may occur, intracapsular rupture of the surface, interperennial hemorrhage may occur, polycythemia due to the erythropoietic function by the tumor, altered erythropoietic functions of the kidney through the uretic pressure. Degeneration may occur. Confirmation of the diagnosis: USG on the color Doppler or saline infusion sonography. It detects the submucous fibroid or the poly. MRI, laparoscopy, hysteroscopy, HSG, and the uterine curettage. Differential diagnosis: pregnancy, full bladder, adenomyosis, myohyperplasia, ovarian tumor, tumors. Now, management protocol for the uterine fibroid. If the uterine fibroid is present and it is symptomatic, then medical management can be done and the surgery can be done. Surgery options are the myomectomy, hysterectomy, myolysis, ambulotherapy. In myomectomy, it may be endoscopy or laparotomy, endoscopy, laparoscopic myomectomy, and hysteroscopic resection of the submucous myoma. Now, on the asymptomatic fibroid, regular supervision for the 6 month is at the interval of 6 months is done if the size is less than 12 weeks. Diagnosis if certain the size increases or symptoms appears, then the surgery is to be advised. If the size is static, remains symptomless, then follow-up can be done every 6 months. Now, surgery is required in the asymptomatic patient if the size is greater than the 12 weeks. Its diagnosis is known, unexplained fertility, diagnosis uncertain, unexplained infertility, recurrent miscarriages, penetrated fibroid, then the surgery is required in the patient, asymptomatic patient. Now, in case of the cervical fibroid, supravaginal and the vaginal, in the vaginal, it may be myomectomy and polypectomy can be done. Supravaginal, myomectomy and the hysterectomy may be done. Now, medical management, if the it is done in the patient, young patient who desires for the pregnancy, to correct the menorrhagia and anemia before the surgery, to minimize the size and vasculature of the tumor in order to facilitate the surgery. In selected cases of infertility, to facilitate the hysteroscopic or laparoscopic surgery as an alternative to the surgery in perimenopausal women or the women with high risk factor for the surgery, where postponement of surgery is planned temporarily. Drug used to minimize the blood loss, antiprogesterone, antigonadotropins like danazol, gestriton, GnRH analogs, agonist, antagonist, levonorgestrel intrauterine devices, also known as the Mirena, combined ossipils, prostaglandin synthetase inhibitors, selective progesterone receptor modulators. Surgical therapy for the fibroids like ambulotherapy, laparotomy, laparoscopy, hysteroscopic removal of the fibroid. Myomectomy may be done, laparoscopic uterine artery ligation, myolysis, endometrial ablation, and hysterectomy. Myomectomy is the enucleation of the myoma from the uterus, leaving behind a potentially functioning organ capable of the future production. Important consideration prior to the myomectomy should be done mainly to preserve the reproductive function. The wish to preserve the menstrual function in paras women should be judicially compiled with. Myomectomy is a more risky operation when the fibroid is too big and too many. Risk of recurrence and persistence of the fibrosis is 30 to 50%. Risk of persistence of the menorrhagia is about 1 to 5%. Risk of re-laparotomy is about 20 to 25%. Pregnancy rate following the myomectomy is about 40 to 60%. Pregnancy following myomectomy should have a mandatory hospital delivery, although the chance of scar rupture is rare. Later move when the cavity is open. Now, the indication for the myomectomy: persistent bleeding despite of the medical therapy, excessive pain or the pressure symptom, size is 12, greater than 12 week, woman desire to have a baby, distortion of the uterine cavity without any other cause, recurrent pregnancy loss, rapidly growth myoma, subserous pedunculated fibroid. Prerequisite to the myomectomy: hysteroscopic or the SH to exclude any submucous fibroid or the polyp or any tubal blockage, hysteroscopic or endometrial biopsy in cases of irregular cycle, not only to remove a polyp but to exclude the endometrial carcinoma. Examination of the husband from fertility point of the view should be done before any procedure. Contraindications of the myomectomy: infected fibroid, growth of myoma after the menopause, suspicious malignant changes, paras women where hysterectomy is safer and it is definitive treatment. Functionless fallopian tube, decision must be judicious with the advent of microsurgery or the ART, pelvic or the endometrial tuberculosis during pregnancy or the cesarean section. Endoscopic surgery, hysteroscopic for the fibroid, but there are the chances of uterine perforation, fluid overload, hemorrhage, etc. Laparoscopy, subserosal intramural fibroid removal can be done by laser, the fibular diathermy. Ambulotherapy, uterine artery embolization causes avascular necrosis followed by the shrinkage of the fibroid. Uterine arteries are occluded by the injecting polyvinyl alcohol particles through the percutaneous femoral catheterization. Magnetic resonance guided focused USG, it causes less pain as compared to the UA. Hysterectomy is the operation of choice for the symptomatic patient where there is no valid reason for the myomectomy. Age is greater than 40 years and in those who desires for the further child. Total hysterectomy is performed, however, subtotal hysterectomy may have to be done in few conditions. Removal of the ovary. It is preferable to remove the ovaries and postmenopausal women and to preserve the same in the earlier age if they are found healthy. Now, the cervical fibroid. This is a presentation of the fibroid, cervical fibroid. This is a picture of the cervical fibroid, a central huge cervical fibroid, also known as a dome on the lantern. Polyp may be tumor attached to the particle. Types of the polyp, it may be mucous, benign or the malignant, mucous, fibroid, placental, or malignant will be denote secondary changes of the benign polyp. This is a sonographic pictures of the endometrial polyp. Mucous polyp, the most common type of the benign uterine polyp is the mucous one. It may arise from the body of the uterus or from the cervix. Risk factors are the HRT tamoxifen therapy, diabetes, hypertension, obesity, and increased patient age. Cervical polyp, symptoms of a cervical polyp, irregular uterine bleeding, either pre or postmenopausal. Contact bleeding of the polyp is situated at or outside the cervix. Excess vaginal discharge may be offensive. Multiple endometrial polyps may cause infertility or miscarriage in young women. Fibroid polyp is due to the extrusion of the submucous polyp into the uterine cavity. Cervical polyp may arise from the active cervix or from its posterior limb. Investigation sonography, saline infusion sonography nowadays not preferred. Hysteroscopy, hysteroscopy, Curitas, sound test to assess the fibroid polyp from the chronic infusion. Placental polyp, a retained bit of placental tissue when adherent to the uterine wall gets organized with the surrounding blood clot. Clinical feature, there is history of the recent childbirth or abortion, irregular bleeding per vagina, and the offensive vaginal discharge are present dated back to the pregnancy event. Management of the polyp, histoscopic and the resection, uterine curettage using ovum fossum. Causes of the recurrence may be incomplete removal, persistence of the cause leading to the polyp formation, malignancy, cervical polyp. Cervical polyp are removed by twisting the pedicle. The base of the pedicle should be cauterized to prevent the recurrence. Histoscopy is useful to locate the position, size, and the base of the polyp. Submucous fibroid polyp resected or aid hysteroscopically. Endometrial polyp that causes infertility, postmenopausal bleeding should be removed hysteroscopically under the direct vision. It is superior to the blind eversion after the polyp is removed. Endometrium is curated to rule out the coexisting pathology. This is the cervical fibroid polyp, which may confuse with the inversion. Thank you.